As clinicians, getting the diagnosis right it's everything, isn't it? And for so long, the way we classified perio was, let's be honest, a little bit fuzzy. So today, we are going to break down the modern framework that brings a ton of clarity and predictability to pretty much every case you'll see.
Remember the old days? It was all chronic versus aggressive periodontitis. But that system really had its limits. There was so much overlap, and it just wasn't very precise. And what we know now is that the evidence just doesn't back them up as two totally separate diseases. So the big question is, what's the new standard? What are we supposed to be using now?
Well, the 2017 World Workshop came along and completely changed the game. It basically redefines periodontitis as one single disease, but it's characterized by these two really important dimensions: its stage and its grade. And what this does is give us a much, much clearer and more actionable picture of what's going on with our patients. All right, so here's our game plan. We're going to walk through how this works in the real world, just like you would in the clinic. We'll start with health versus gingivitis, then jump into how to actually diagnose periodontitis. After that, we'll get into the nitty gritty of staging for severity and complexity and grading for risk. And finally, we'll see how to put it all together for a complete diagnosis. Okay, section one, a new framework, moving beyond chronic and aggressive. So, what does this actually mean for you day to day? It means we can stop trying to shove patients into those old, clunky, chronic, or aggressive boxes. It's so much simpler now. A patient either has periodontitis or they don't. That's it. The real power is in how we describe that periodontitis, using stage and grade. That's what lets us create a really personalized and super accurate assessment for each person. All right, section two, health versus gingivitis. This is all about establishing that baseline. So, when a patient sits in your chair, the very first decision you have to make is a big one. Are we looking at periodontal health, or do they have plaque induced gingivitis? Seriously, this is the fork in the road that sets up everything else. So, what are we aiming for? Clinical periodontal health. And what does that mean? It really boils down to one main thing: the absence of detectable inflammation. No bleeding on probing, no redness, no swelling. And this is important. This definition applies whether they have a totally intact periodontium or one that's already been reduced from past disease. The key word here is stability. Okay, so how do we measure this? It comes down to a number, a really important number: less than 10%. That's the magic number. If your patient has fewer than 10% of sites with bleeding on probing, or BOP, you can call that clinical health. But the moment they hit 10% or more, they've crossed the line into gingivitis. It's a nice, simple, objective way to look at it. And this flow chart here, it does a brilliant job of showing the patient's journey. See that cycle on the left? A patient can bounce back and forth between health and gingivitis. With good hygiene, you can reverse it. That's the key. It's reversible. But once they cross that line over to the right into periodontitis, the attachment loss that happens is, for all intents and purposes, irreversible. This is such a critical concept to grasp. A perio patient is a perio patient for life. Even if you get them stable and perfectly managed, they always carry that history and that risk. Okay, think of this table as your go to cheat sheet in the clinic. It lays it all out. So let's look at the top two rows first. This is for patients who've never had periodontitis. You'll notice the pocket depths are the same, right? 3 millimeters or less. The only thing that pushes them from health into gingivitis is that bleeding on probing hits that 10% mark. Now, pay close attention to that bottom row. This is for our stable perio patients, and it's so, so important. We can actually call them stable and healthy, even if they have some 4 millimeter pockets. But here's the catch: there has to be zero bleeding on probing at those deeper sites. Section 3, diagnosing periodontitis. Let's talk about identifying the case. So, what's the actual trigger? How do you know for sure that a patient has crossed that irreversible line from gingivitis into periodontitis? Well, the official definition is very, very specific. The whole thing really hinges on finding interdental clinical attachment loss, or CAL, at two or more teeth that aren't right next to each other. And just as important, you have to be sure that the CAL isn't from something else. Like recession from brushing too hard, a cavity, or a wacky third molar. It has to be from periodontitis. Okay, on to section 4, staging. This is all about severity and complexity. So once you've made the diagnosis of periodontitis, you have to describe it. And that's where staging comes in. Staging basically tells you two things: how severe is the disease right now, and how complex is this case going to be to manage? The process for staging is actually pretty logical. It's a simple three-step evaluation. First, you figure out the initial stage. You're going to use either cal or radiographic bone loss, whichever is worse. Second, you have to account for any teeth the patient has already lost specifically because of periodontitis. And last, step three, you look at complexity factors, things like furcation involvement or vertical bone loss. These are the things that can bump a patient up to a higher, more severe stage. Okay, now this table, it looks like a lot. I know. It lays out all the criteria for every stage. It can definitely feel a little overwhelming at first, but trust me, the logic behind it is really solid. So let's just focus in and break down the key severity markers, specifically that interdental CAL, because that's usually where you're going to start. All right, stage eye. This is initial periodontitis. See, earliest you can catch it. We're talking about just 1 to 2 millimeters of interdental KAL at the worst spot. Usually no tooth loss yet. The management here is pretty straightforward. Then we have stage two, which is moderate periodontitis. Now we're looking at established disease. The CAL at the worst site has now crept up to 3 to 4 millimeters. So the destruction is obviously more significant. But we're still mostly dealing with simple horizontal bone loss, not the really complex stuff we see later on. Now, stage three. This is where things get serious. This is severe periodontitis. The interdental CAL is now 5 millimeters or more, and this is where all those major complexity factors start popping up. We're talking deep pockets, 6 millimeters plus, vertical bone loss, class 2 or 3 furcations, and this is the stage where losing teeth because of perio becomes a real possibility. And finally, stage four. This is advanced periodontitis, the most severe form. The attachment loss numbers might look similar to stage three, but the huge difference here is the complexity of just getting the patient functional again. These are the cases where you have bite collapse, problems chewing, severe ridge defects. You're literally worried about them losing all their teeth and needing a full mouth rehab. All right, let's switch gears. Section 5, grading, which is all about risk and progression. So if staging tells us about the damage that's already been done, the severity right now, grading gives us a peek into the future. It's about the biology of the disease, how fast it's moving, and what the patient's future risk looks like. So this table here shows you how to figure out a patient's grade. It goes from grade A for slow progression all the way to grade C for rapid progression. Here's a great tip. You should start by assuming every patient is a grade B, a moderate rate. Then you look for evidence that would either shift them down to A or up to C. And honestly, for most of us in the clinic, the most practical, actionable part of this whole thing is going to be the grade modifiers. So let's zoom in on a really critical one: diabetes. If a patient doesn't have diabetes, that's a grade A modifier, low risk. If they do have diabetes, but their A1C is well controlled, under 7.0%, they're considered grade B. But, and you really got to remember this, if their HbA1c is 7.0% or higher, that's an automatic grade C. That signals a high risk of rapid progression, no matter what else is going on. Okay, section 6, the complete diagnosis. Time to put it all together. So we've done all the work, we've assessed the severity, the complexity, the risk, and now we're going to combine the stage and the grade to create one single complete diagnosis. So you might end up with something like this: generalized periodontitis, stage 3, grade C. And just think about how much information is packed into that one little sentence. It tells you the disease is everywhere, it's severe and complex, and this patient is at high risk for it getting worse fast. I mean, that is just an incredibly powerful tool for talking with other clinicians and for planning your treatment. And this quote from the original paper really sums it all up perfectly. It says, staging is largely dependent upon the severity of disease at presentation, while grading provides supplemental information about biological features of the disease. I mean, if you take one thing away from all this, it's that distinction. Stage tells you where the patient is right now, how much damage has been done. Grade helps you predict where they're going. It's all about their future risk. Thank you for watching. Check out these QR codes for more information.